This session consolidates what you have been learning about edema across different body systems and its mechanisms, causes, and clinical presentations. Edema is the abnormal accumulation of fluid in the interstitial space of tissues or within body cavities. A classic bedside sign is pitting as shown here. After applying firm finger pressure for a few seconds, a depression remains that can persist for minutes if significant interstitial fluid amount is present. The formation and reabsorption of interstitial fluid primarily depends on Starling's forces. Capillary hydrostatic pressure drives fluid of the capillaries into the interstitium. Plasma colloid osmotic pressure pulls fluid back into the capillaries. Interstitial hydrostatic pressure resists outward fluid movement, and lymphatic circulation is crucial for maintaining interstitial fluid volume by removing excess interstitial fluid and returning them to the venous system. You have learned multiple causes of edema. All these can be grouped under one or more 4 fundamental mechanisms. So, decreased plasma oncotic pressure, which is less pulling back into capillaries, and increased capillary hydrostatic pressure, which is more pushing out of fluid into the interstitium, and increased capillary permeability, which is leaky vessels, and lymphatic obstruction, which impairs removal of interstitial fluid. Now let's look at some examples of these mechanisms. So, heart failure and renal failure lead to sodium and water retention. This will increase intravascular volume. So, venous capacitant vessels distend, resulting in increased hydrostatic pressure at the venular end of capillaries, impairing return of interstitial fluid into the circulation, producing pitting edema. And deep vein thrombosis is a cause of local venous obstruction which raises hydrostatic pressure in the affected limb. Now here the raise happens in a localized area, so it causes unilateral edema. And with regards to reduced plasma oncotic pressure, it commonly happens with hypoalbuminemia, which may happen either as a result of decreased protein production, for example in severe liver disease or malnutrition, or in increased protein loss in conditions such as nephrotic syndrome. So this diminishes reabsorption of interstitial fluid and promotes edema. An increased capillary permeability is seen with infections, inflammation, and trauma, where the endothelial integrity is disrupted. And lymphatic obstruction happens with malignancy infiltrating lymphatic channels and filariasis. Filariasis is actually less common today, and all these can block the lymph drainage, resulting in lymphedema. Edema can also be classified by distribution. Localized edema can arise from lymphedema. For example, it can be post-surgical, resulting post-trauma, or deep vein thrombosis or chronic venous stasis. Localized infections such as cellulitis or myositis or inflammatory conditions such as allergic reactions can produce localized edema, for example, angioedema. Generalized edema may result from causes such as cardiac failure, renal failure, liver disease, nephrotic syndrome, severe malnutrition, certain drugs, and systemic allergies. These images demonstrate clinical examples of unilateral edema. The image in the left-hand side is a leg with deep vein thrombosis. The affected leg appears larger and erythematous, and in these patients, on physical examination, we often note calf tenderness. And the second image is a patient post-mastectomy and radiotherapy. So in this instance, clearance of axillary lymph nodes disrupts lymphatic drainage from the arm, producing unilateral arm edema, which is lymphedema. And this is angioedema, which is an example of localized allergy-mediated edema, which is characterized by rapid swelling of subcutaneous or submucosal tissue. So here you can clearly see the swelling of the face, particularly around the patient's lips. Now let's look a bit more deeper into mechanisms of edema in specific conditions. So how does renal failure cause edema? In patients with renal failure, the glomerular filtration rate is reduced. This can be in both acute or chronic kidney disease, which impairs sodium and water excretion. And this results in intravascular fluid retention, which increases the hydrostatic pressure of capillaries, leading to edema. How does nephrotic syndrome cause edema? In nephrotic syndrome, heavy proteinuria lowers the plasma albumin and oncotic pressure, driving fluid into the interstitial spaces. So this results in edema. In addition, there's another mechanism that contributes to edema in these patients. The resultant underfilling of the effective circulatory volume activates the renin-angiotensin-aldosterone system. This causes secondary sodium and water retention, which further contributes to edema in these patients. So this is an image of a patient with nephrotic syndrome, and he has puffy eyelids. The periorbital puffiness in these patients is often more prominent in the morning. So this happens because of the nocturnal fluid redistribution. So in the mornings, there's more fluid accumulating around the eyelids, which is manifested as facial puffiness. So in the initial stages, it might be just mild facial puffiness, but as the disease advances, the patients may develop significant and gross edema. Now, let's look at how cardiac diseases result in edema. Let's start with left heart failure. So in left heart failure, the myocardial contractility and pumping is reduced, and this will result in a reduction in stroke volume. And one thing which happens with that is a reduction in renal blood flow, which activates the renin-angiotensin mechanism, resulting in salt and water retention. So this will increase the venous pressure at the capillary end and resulting in an inability of the fluid to return back into the vascular space. So this causes edema. In addition, in left heart failure, there's back pressure effects on the pulmonary circulation, which results in pulmonary edema. So as illustrated in this image, patients with left heart failure have pulmonary congestion, resulting in pulmonary edema, and the fluid retention will contribute to systemic fluid retention as well, which causes an elevated JVP and lower limb edema. So in right heart failure, the elevated systemic venous pressure causes marked JVP elevation, tender hepatomegaly and ascites and peripheral pitting edema. Pulmonary edema is not a dominant feature because the primary pressure elevation is in the systemic venous circulation. And in addition to this, renin-angiotensin activation happens from reduced effective arterial blood volume, which further aggravates the fluid retention and edema. So this slide summarizes the patterns of edema in left and right heart failure. So in left heart failure, predominant feature is pulmonary edema and pleural effusions. Also, the patients have peripheral edema from activation of the renin-angiotensin-aldosterone axis. In right heart failure, the prominent feature is systemic venous congestion, which is manifested as elevated JVP, hepatomegaly, ascites and peripheral edema. These patients generally do not have pulmonary edema. In liver disease, multiple mechanisms contribute to edema. Firstly, reduced synthetic function results in a reduction in albumin production, which reduces the plasma oncotic pressure, resulting in transudation of fluid. Second, in patients with liver disease, portal hypertension raises the pressure within the portal venous system, which results in transudation of fluid predominantly into the abdominal cavity, resulting in fluid accumulation in the peritoneal cavity, causing ascites. Another mechanism that contributes to edema is splanchnic vasodilation. So this will result in relative underfilling of the splanchnic circulation, and this will trigger activation of the renin-angiotensin-aldosterone system as well as activation of vasopressin. So all these will subsequently result in salt and water retention. Another mechanism that contributes to edema is reduction in aldosterone metabolism, which increases the aldosterone level, further contributing to salt and water retention. So, the key takeaways in this session are that any condition that produces edema does so through one or more of the four following mechanisms. It can be either increased capillary hydrostatic pressure, decreased plasma oncotic pressure, increased capillary permeability, or lymphatic obstruction. In preparation for the large class discussion, take a few minutes to map the mechanisms of underlying edema in each of these listed conditions that we've been covering, and this is a good learning exercise for you to work on. Particularly, this will help you as you meet patients with edema to work out on the possible causes of edema. Thank you.